Okay, thanks for joining us for Discussions in Diagnosis. We took a little bit of a break for a while due to travel schedules, vacations, etc. But we are back with Dr. Moshe Prero, who is one of our own. He's here at Rainbow Babies and Children's and University Hospital. So welcome. Thanks for joining us, Moshe, this morning.
Yeah, thanks for having me.
So we're going to talk about a kind of a vexing problem that I've struggled with for 20 plus years. I used to be in the Department of Pediatrics at the University of Pittsburgh and ran the pediatric obesity program there. And it's interesting. I was looking at guidelines for diagnosis of obstructive sleep apnea in children from the AAP. The last one was 2012, so 11 years ago. Before that was 2002. And I was looking at them, and there was not a whole lot of changes in recommendations there, which was a little surprising. So let me start with a scenario for you that I think many of us, whether we're in primary care or not, might encounter. And let's say I've got an 10-year-old boy who comes in, annual well child visit, which is pretty common, obviously, at this time of year. Mom says he snores. And he is overweight. He doesn't really have anything else identifiable, no headaches, no behavioral problems that we can tell. He shares a room with younger brother who's 8, who says, well, maybe sometimes he stops breathing. I asked the child and mom about whether he's sleeping in the daytime. I don't get great responses that are meaningful that I can use and say, oh yes, he definitely has daytime somnolence. So maybe starting at that very early point, Moshe, what would you do from that point?
Yeah, that's a great question. And I think referring to those AAP guidelines, those 2012 guidelines that you referenced, is a good starting place. Because in this scenario, those guidelines recommend screening for obstructive sleep apnea by asking a simple question. Does your child snore? So asking that at the well visit. And if the answer is yes, then you proceed to probe, which in this case we did a little bit. And he stops breathing, but he doesn't have headaches. He's not sleepy during the day. There are a few other symptoms that are more commonly presented that children present with as compared to adults. So in adults, a very common manifestation of obstructive sleep apnea is daytime sleepiness. And in fact, in children, that's less common. We see that more if it's more severe on the severe spectrum of obstructive sleep apnea. But in general, the more common symptoms are things like behavior symptoms, inattention, mood issues. So I usually prompt in that scenario that you presented, I usually probe a little bit more and really try to get a sense of what the parent or the guardian or who's ever with that child, if they can tell me a little bit more about their behavior, their school performance, their attention, and try to elicit, I guess, collateral history. What do the teachers say about in this case this boy? What do you get any reports home from school about his attention during school? How are his grades? So they say he's dozing off, which would be excessive daytime sleepiness. Any behavior problems? So sometimes I find that helpful, and often, as we all do, if a behavior is common, parents might say, "Oh, there's no behavior issues. That's just how my child is." They've always been one sort of with not being able to sit in their seat for a long time. But when you listen to that and say, "Well, they're snoring and they have pauses in their breathing, but there's some hint of they have this inattention or hyperactivity," those can be signs of OSA. So long story short, once you get the history of snoring, you look for those other symptoms, namely attention deficits, behavior changes, learning problems, daytime sleepiness, along with other comorbidities like hypertension or obesity. And if those are present, then that's a reason enough to refer to a specialist. So those AAP guidelines talk about referring to either an ear, nose, and throat specialist or a sleep specialist. And I believe, talking to people who are on those guidelines or around when those were written, that's really because there's a lack or dearth of pediatric sleep specialists and specialty pediatric sleep labs as well.
Okay, well, thank you, Moshe. That's really helpful. So I know that many years ago, there was somewhat of a push to use formal questionnaires, either completed by the parent, maybe completed in Epic, maybe completed in advance to help identify some of the symptoms that you were talking about. How do you feel about some of those questionnaires? Should we be using them?
Yeah,
Like
well,
Harris questionnaire, things like that.
yeah. A lot of these questionnaires have been validated for research purposes, and they're good for research purposes, some of them. So for instance, the pediatric sleep questionnaire has a sleep breathing disorder related section. And that for research purposes, in terms of identifying presence of OSA, has a sensitivity and specificity of over 80%, maybe over 85%. So that's used commonly in research studies, and it's pretty good about detecting the presence of OSA, but it doesn't necessarily correlate with the severity, like PSG measured severity of OSA. And so, it's helpful to sort of, I find them helpful. We have them in our questionnaire in our sleep clinic and our intake. Find them helpful to sort of elicit those questions that we're going to ask anyways, and sort of do it in a formalized, standardized manner. But it doesn't replace the PSG. Other things like the Epworth, for instance, which is not a measure of OSA, it's a measure of daytime sleepiness. But that has to be used. There's a pediatric specific one, that takes out the questions about alcohol and falling asleep while driving. And again, it's useful for measuring, for having an objective measure of daytime sleepiness that you can track over time. But again, in terms of diagnosing OSA, it's not, they're not used to diagnose OSA.
Okay, that's really helpful. So I think what I hear you saying is these questionnaires can be useful to review, perhaps, for those clinicians that see children. But after a while, you'll probably get familiar with the questionnaires themselves, and hopefully it'll raise some awareness about the questions we ought to be asking.
Yes, absolutely.
Yeah, that's great. So talk to me a little bit about PSG options for sleep studies, whether we refer, you mentioned the dearth of pediatric sleep specialists. That's a problem even here in Cleveland in a major medical center. But what are the options for sleep studies right now in children?
Yeah, and this is a really important point. Two things that I want to point out. One is you have to know the area that you're practicing in. I just talked to a colleague, I'm not going to say which institution they're at, but he told me that he was frustrated that he's referring patients who have, frank snoring and obstruction, and the sort of the culture in that institution is to refer everyone to a PSG. And he said it's like a 10-month waiting period for a PSG. And so you have to consider, right, the clinical problem in front of you, and then the resources you have to address it. And so that, in terms of pediatric sleep studies, that is a major consideration. But in terms of the technical sort of steps, logistics of ordering it, what goes into it. So one very important piece of information is that when ordering a sleep study, it will get denied by insurance if you put the indication as snoring. If you associate snoring as a problem, that's not an indication from an insurance perspective for a PSG. What you need is, in the current ICD codes, is the problem called sleep disordered breathing. And essentially what that indicates is that you've followed the AAP's guidelines. So you've identified that there is a problem with breathing during sleep. So that's the snoring, pausing, gasping, witness apneas, or plus impact on daytime functioning. So in fact, when I order a PSG, that's the first step. I have the correct problem, which is sleep disordered breathing, and I document in my note, I said this patient has sleep disordered breathing as evidenced by their breathing disturbance during sleep, and there has impact on daytime functioning as evidenced by, so I sort of lay it out there. So it lessens the questions that I get from insurance companies when they want to review the study. Some things that are specific to pediatric PSGs. CO2 is standard. Measurement of CO2 is standard in pediatric PSGs as opposed to adults, where it's not standard. The reason for that is that there is a pattern called obstructive hypoventilation, where you can see if a child has obstructive sleep, obstructive breathing during sleep or specific periods, let's say in REM periods, their CO2 will start to rise during that period and fall. So it's actually very helpful. It's a specific pediatric pattern of obstructive breathing. And we're also looking for hypoventilation disorders as well. So CO2 comes standard, whether that's end-tidal CO2 or transcutaneous CO2. Another major difference between pediatrics and adults is where do you have the sleep study perform? Standard of care right now is that all pediatric sleep studies are done in let's say, the vast majority of pediatric sleep studies are done in the sleep lab. Whereas adults, often the insurance will mandate you to have 1 or 2 home sleep apnea tests before you actually make it to the sleep lab. They have looked at, and the American Academy of Sleep Medicine reviewed home sleep apnea testing for pediatrics and within the last decade, and they said there was not enough evidence to support it. Subsequently, there have been some more and more small studies that have come out looking at home sleep apnea tests, and so in children, and so I think they're going to review the literature again at some point and may update based on what they've found. But in general, the sleep studies are done in the lab, and home sleep apnea tests may not be covered. So if you, for whatever reason, want to do some home sleep apnea tests, it's worthwhile to check with insurance. Another major difference is that in the adult world, it's standard to order a split night study, right? You have a high index of suspicion that your patient has obstructive sleep apnea, so you want to make the most of that night in the sleep lab. You order, they need 2 hours of sleep where they can make a diagnosis of OSA based on the AHI, and then use the rest of the night to initiate PAP therapy, CPAP or bilevel. In pediatrics, because that's not standard, it's usually done either on 2 different nights. So you have a dedicated diagnostic night, and then depending on insurance, you can initiate CPAP in lab or at home, but it depends on the insurance. So that's something that has to be looked into. Oddly enough, when I've had patients, let's say older teenagers, who I have a high index of suspicion, they're basically adults physiology-wise, and I say, let's just do a split night. You'll get it done in one night. And I've gotten denied a number of times by insurance. They say, we need it on 2 separate nights. So, the ins and outs, the logistics make a huge difference.
Yeah, so just to address that's really helpful. And especially, I think the ICD-10 coding that you mentioned is going to be really useful for us. But one of the problems I faced, Moshe, is just the practicalities of getting a 6-year-old boy to spend the night in an unfamiliar environment, to fall asleep in a timely fashion. The picture I used to show in our pediatric obesity center was a dad who was a pulmonary sleep specialist like yourself, lying down with his son, which is what he would have to do. But what accommodation, how do you make it easier for the child to go through this process, especially if it's 2 nights? That seems like a lot for.
Yes, it is. So, and this is why I think a referral to a sleep specialist in our setting, let's say, where we have sleep specialists available, we have dedicated sleep nurses, we have a sleep psychologist if needed, can be helpful if the child needs a lot of prep and may encounter that difficulty. So first of all is education, right? So for instance, our sleep center has published a book chapter on how to make the sleep lab friendly, a child-friendly environment. And it starts from, how do you introduce the sleep study? How do you introduce all those sensors that are going to be applied to the child? So you have to use developmentally appropriate language. I don't say leads, I say stickers. I don't say we're going to put a cannula in your nose. I say we're going to put it under your nose. And you can get creative. There's a microphone for snoring, and you can say, we'll have a movie star. My mentor, Dr. Carol Rosen, would say, we have a movie star microphone on you, and sort of make it a fun experience for the child. They're going to have a sleepover in our sleep lab, spend the night with us. So you're using child-friendly language. In addition to that, having PSG techs who are experienced with children can take a lot of that anxiety away. prepping them with the parents with videos and what to expect. It's an outpatient procedure. If your child has medicines, bring those with. We don't provide those. And then finally, for children who have developmental delays or issues, behavioral issues, we do have special accommodations. Let's say at our sleep center, we have child life specialists available once a month. So those are dedicated spots, but they can come, they can help set up the child using a teddy bear to show how the leads go on and everything to model it. All that being said, is we have had success with neonates, infants, children with autism spectrum disorder, all types of developmental delays in our sleep lab. The data is not always pristine in terms of the interpreting. When I look at a sleep study, right, you can have long periods of wake time, but often, I'd say as a rule, we get enough information to make a determination of whether OSA is present and the severity of it. From time to time, there are patients who don't sleep. Sometimes we have to have the conversation ahead of time of with all these sensors. Let's say I have a child who's severely averse to anything on their face or head. So that's like, how do we run a sleep study?
Yeah.
So then we have the conversation of the sensors that are included in a sleep study. Which ones do we absolutely need to make the diagnosis?
Okay. Yeah.
So it's a lot of negotiating, knowing what goes into the sleep study, and then knowing what data do I need to help the patient in front of me.
Great. Are parents, is there a place for a father or mother to stay over with the child?
Yes. Yeah.
Okay.
One adult. There is room in our sleep labs. We within university hospitals, we have not every sleep lab does pediatrics. So you have to know we do at Bowell, and now we're starting to branch out. Parma is doing younger than 6 as well. But yes, there's a place for one parent or guardian to come with. An adult has to spend the night with the child.
Okay, terrific. So as a final question, I don't know, the guidelines might seem old, they sound like they're still valid, they're still important, but where do you see the future of diagnosis of obstructive sleep apnea in children or central sleep apnea, it doesn't matter?
Yeah, this is the sort of burning question in the field of sleep medicine in general. So like you mentioned, the guidelines are from 2012. There's a landmark study called the CHAT study looking at treatment of obstructive sleep apnea with denotonsillectomy that came out in 2013. And then there's a new study called the PATH study, which is the results are about to be released. They're looking at mild sleep disorder breathing and the impacts on neurobehavioral outcomes and the denotonsillectomy. So the field is getting more and more data, like we're becoming more and more data driven. At the same time, we're realizing that existing standards for measuring OSA aren't really sufficient for the evolving picture. And I'll give you a specific example. So this new trial that's coming out, the PATS trial, they released some data from it. And one of the surprising features, so this was like 459 children between the ages of 3 and 12 with what they called mild sleep disorder breathing, meaning they had an AHI less than 3. And they compared those children to a previous study which is the CHAT study in 2013, which had a similar number of children ages 5 to 9 with AHI from 2 to 30. Okay, so a larger range of AHI. And what they found was that some of the executive function and behavioral, attention was actually worse in the mild sleep disorder breathing than in the children in the previous study with higher AHI. So how do you explain that? Like that leaves with a lot of questions looking at the AHI as a biomarker of severity for OSA. It's easy enough to measure, right? There are specific things we look for, so it makes it a nice marker. But these sort of arbitrary cutoffs, and I forgot to mention in pediatrics, the cutoffs for mild, moderate, and severe are different than in adults. In adults, it's AHI of 5 is mild, 15 is moderate, and 30 is severe, whereas children it's 1, 5, and 10. So, and even this is not, I've talked to the people who've heard lectures and talked to the people who were involved in making those cutoffs from the data that they had when they were established, but they themselves admit that they're not sufficient. So number one is looking at what biomarker should we be using? Is AHI sufficient? Are there other variables that we're collecting during sleep that could be used that can look at heart rate variability, for instance? These are some things that are looking at the EG and sort of a more micro level. These are things that are being talked about. No one has a good answer just yet, but I think the field is evolving that way. Number two is, what we talked about. The technology is evolving, and I think there's going to come a point where home sleep testing will become a thing in children. Like, the technology should be good enough. If it's not there, it should continue to develop where that will become I believe the field is heading in that direction, where we'll have the ability to do that. We don't have it now. And again, the literature has to be reviewed, but there are devices that are being produced and being trialed that can do almost everything that a PSG can do, but in the home environment. So I think that's something to look at as well. Wearables is a whole nother area. Are the watches or the other type of wearable rings or other type of wearable devices, they're getting pretty good. And so there is a whole committee. The American Academy of Sleep Medicine has a whole committee, and they have a hard time keeping up with all the new technology that's coming out, but they're trying to assess that. And I think that's an area that will be developed. So those are some of the areas in diagnosis. And then in treatment, that field is evolving as well rapidly. I think we're sort of on the cusp of a new era. We're not there yet. At this latest meeting at the American Thoracic Society in May, I was at a session where there were 3 or 4 groups that presented pharmacotherapy for different drug trials for OSA, thinking about the anatomic or physiologic source of the obstruction. How can you stimulate or prevent the obstruction at those areas? And there's also nerve stimulation, like electrical nerve stimulation, which has been commonplace for the right patient in adults and is now making its way to pediatrics. So as with everything in medicine, the treatment starts in the adults because there's more adults to do trials, to do research, and then it sort of trickles its way down to pediatrics. So those are some of the directions that I think the field is going in.
That's fascinating. Thank you, Moshe. So we have a couple of minutes left, and just a few minutes. Thanks for a great discussion. For any questions or comments from our attendees this morning, let's scroll through and see. Please unmute yourself if you have a question.
Good morning. This is Brian Zach. Thank you, Dr. Prero. My question is, as a pediatric primary care provider, and you touched on it briefly about 10 minutes ago, but I wanted to follow up. We have lots of reasons to suspect disordered sleep in our patients, and we refer commonly to your practice and to your partners. My question is, should we, through this type of education, be more willing to order those sleep studies without your consultation? I assume the answer is yes, because you're educating us. But the question is, what would be red flags specifically, or green flags, if you want to go that way, ones we should initiate before referral versus ones that definitely need referral? I have an overview in my head, but I'd love to hear what you have to say.
Yeah, fantastic question. And I agree with you. As long as that education piece is there, you're comfortable with counseling the patient on what to expect in the sleep lab. I absolutely, you can do a direct referral to the sleep lab and cut out the wait time to get into sleep clinic. If it's a slam dunk case. I think that the special considerations are anything that Goutham sort of touched on, like, how do you know this child's going to sleep in the sleep lab, or if there are a comorbidity that might mean other things. So I'll give you an example. So a child with trisomy 21 or any other neurodevelopmental disorder who's going to need some hand holding or at least prep. send to us. That's a referral to sleep medicine. Anyone with excessive sleepiness, where you're like, think that this might be more than just obstructive sleep apnea. If you're starting to think about things like narcolepsy, that would be things to send to us. You know, any child with a complex medical needs, neuromuscular weakness, there might be special considerations about mobility or about testing. I would send to sleep medicine. But if it's run-of-the-mill sleep apnea, you know, by testing, by those screening questions, then yeah, go ahead and order it. And if you need help, you know, you can always reach out to us in terms of resources. We have our website, our pediatric sleep website, which has resources about the sleep lab as well.
Great, thank you, Moshe. We'll take one more question if we have one. If not, we can wrap up for this morning. Okay, I think we're good, Dr. Prero. Thank you so much. Fantastic discussion. I wish we had another half hour. I've got a bunch of questions myself, but thanks everyone. Have a wonderful day, and we'll see you next time. Next time we have a guest, hopefully we'll be within the next couple of weeks. Take care, everyone. Bye-bye.
Thank you. Bye.